don't see my slides. Okay. Hi, good afternoon from the Montreal Heart Institute. Once again, we have the pleasure to showcase some of the team's efforts in helping patients with coronary artery disease. If you can show me my slides right now, I don't see my slides. So today I'm joined by my excellent, very senior fellow soon to be done, Marcel Santalo. He's going to go back to Barcelona. So we have the pleasure also to work with Dena Carrier, who's here with us as the scrub nurse. So we'll move quickly into the case. This is an 89-year-old gentleman who presented with chest pain after an activation of our EMS system for chest pain, and the initial field EKG showed ST elevations in inferior leads. He was in the last day transferred directly to the cath lab for an inferior STEMI, KILIP 1. As you can see from the slides, he's only known for, he has risk factors such as dyslipidemia, and he was known to be pre-diabetic and had a past history of depression. So post primary PCI of his RCA, the clinical course was unremarkable at day 1 of CCU. You could see the troponin HS peaked at 669. His hemoglobin and his platelets were unremarkable. The EGFR is actually very good for despite his age. He is now officially, according to blood work that we more recently did in the last 24 hours, diabetic with an A1C at 6.9. A transthoracic echo was done on admission in the CCU, and the LVEF was deemed normal. And clearly, due to his STEMI, there was a regional wall abnormality in the inferior basal territory, and valves were rather good for his age. What you need to know for this patient, he lives in a retirement home, but is quite active and autonomous. He still drives, manages his own affairs as well, and fully functional and no frailty. So next slide. So now we'll review the angiogram. Do you see the angiogram now? Let us know once you see the pre and post angiogram of. So what we're showing you now is the pre and post images of his RCA. As I mentioned, he was admitted to the CCU due to an inferior STEMI in the mid portion, right after that marginal branch that you see. And that's to the left of the screen. The right of the screen is post 3.0 stent, 3.0 by 18 stent in his mid RCA. We'll move on now to the diagnostic images of the left. So this is an RAO caudal that you can see. So he has severe disease in his prox LAD, which is of significant caliber. Next, this is an RAO crani. You can, before the injection, you could clearly see there's a high burden of calcium, and the angulation will be shown even more in the next few images. What you can remark as well is his ramus branch. As note, the catheter right now is a 5 French catheter in the diagnostic. Next image. So again, you will see the ramus branch and the significant tortuosity in the prox LED will be seen afterwards in the spider view. Next. If you pay close attention, there's actually a collar at the level of the osteo LAD, so we have a bit of wiggle room. There is an important mismatch between the left main as well as his LAD. There's a retroflex circ, but the ramus branch is, when you compare it to the 5 French diagnostic, is not is around 2, but certainly not 2.5. Okay, move on to the slides now. Est-ce qu'on peut avoir les diapos? Okay, next. So what we basically have is an 89-year-old gentleman with multivessel disease, significant multivessel disease with moderate to severe calcium already assessed by angiography. Procedural considerations, radial versus femoral, we elected to go radial. Standard guiding, 6 French XB35 and a workhorse BMW was planned. Next. So points of discussion, post-STEMI, what do we do with multivessel disease, vascular access in the elderly? Is this a true bifurcation when you're looking at that ramus branch near that LAD? The place and importance of intracoronary imaging modality in cases such as we have due to the importance of the calcium. And what do we do with calcium modification? Is this an IVL case, an atherectomy case? And also, as he's 89 with an ACS status, you have to make sure that there's no HBR risk here, high bleeding risk, and the duration of the DAPT. Next slide. So just to answer some of the questions, points of discussion, the complete trial was published a few years ago by Shamir Mehta and his group. Next. This is a a study in post-STEMI patients with multivessel disease and successful PCI of the culprit lesion. And patients were randomized if they had another disease non-culprit lesion with at least a 2.5 or higher diameter. And a stenosis, angiographic stenosis of 70%, or an IFR that was FFR that was positive if it was an intermediate lesion. So over 4,000 patients were randomized in each arm and were followed for 3 years. Next slide. As you can see, this was published in 2019. Next slide. And clearly compared with culprit-only PCI, routine non-culprit PCI for complete revas resulted in reduced events, CV death or new MI by 26% with an NNT of 37, whereas it also reduced CV death, a more composite endpoint of reduced CV death, new MI, or new ischemia-driven revas by 49% with an NNT of 13%. And you clearly see an early separation, which is maintained through the 3 years and with the 5-year follow-up as well in both of these co-primary endpoints. Next. In terms of timing, this is important. The timing of the PCI within the hospitalization versus outside of the hospitalization, median day of a median time of day one, which is our case here, and it could always go all the way up. The benefit is maintained when you do your PCI within 3 weeks post discharge, and there were no significant differences in bleeding, stent thrombosis, AKI, or stroke. Next. However, PCI in the elderly or very elderly has special considerations to bear in mind. This was actually well published in a concise review recently. Next. However, there are many considerations to bear in mind and of importance for us. Stent type should not, elderly patients or the very elderly should not have BMS, which was actually something that was deemed in the past suitable for them. And I think now the data DES is also the preferred choice. Next. PCI in the elderly or the very elderly is not without hazard despite modern era PCI and all of the technologies that we have. This was reviewed and published by a Japanese group in a JPCI registry. As you can see, they separate between ACS patients versus stable ACS. Almost 210,000 patients were stratified according to their age range from sexagenarians to nonagenarians. Next. And you can see in the ACS cohorts, as you increase your age, there's an incremental risk of event in hospital mortality, as well as bleeding risk compared to the more stable patients. Next. And this is seen again in a different graph that the bleeding complications versus the in-hospital complications are actually higher in terms of when you look at the y-axis in terms of risk for such patients. Next. For consideration as well in patients that are in the elderly to very elderly category, you have to make sure that there's no high bleeding risk. As was published previously in Circulation and European Heart in 2019 as well. One major criteria versus 2 minor criteria will give your patient an HBR status. In our case, if you look to the right of the screen, in all of the labs and all the clinical status of the patient, the only one criteria we have is a minor one, which is the age above 75. So he's not considered an HBR patient. Next. So how do we manage this? How do we reduce this? We try to mitigate this by using recent literature, which is intercoronary imaging and its impact on outcomes. So this is, as most of you know already, the Renovate complex PCI. Obviously, due to his age, this patient would probably never have been randomized, but we can extrapolate from this data. However, in this case, we consider this a complex PCI as it is a proximal lesion of a major epicardial artery, and there is a severe calcium, and this was a multivessel PCI if we consider also both lesions on the left and the lesion on the RCA. Next. Salient features of this study, half of the patients were in ACS, and these patients were moderately complex in terms of clinical criteria, not being that many diabetic. Less than a quarter of them had prior PCI, and the LVEF was normal. But again, this fits with our patient. And procedural success in such patients with imaging guided PCI was 98%. Most of the study was performed with IVUS compared to OCT. Next. And you can see that the curves also split very early within follow-up and is maintained in terms of the primary outcome, which is target vessel failure. Next. So let's look at what we've done up to now. So the decision for us, clinically speaking, after discussing this obviously with the patient and the treating physician in CCU, is to proceed with PCI of the vessels that we have. And as I shown you with the orbital data, with the complete data, I mean, the vessel size needs to be 2.5 and above. If you look at that Ramus branch, it's likely less than 2.5. So the decision was made not to tackle today the Ramus branch, but actually go for that prox heavily calcified LAD and see upon follow-up and optimization for his guideline-directed medical therapy if there's a need to move forward with a subsequent PCI of his Ramus branch. Je ne sais pas si on peut montrer encore l'image de l'IVA, de l'ancienne image de l'IVA on Spider. So if you look at the, we'll try to show you the previous angio to have an idea of the Ramus branch again. Est-ce qu'on peut montrer les images de l'ancien? So we're trying to show you the previous images. So if you look at the 5 French diagnostic left versus the branch itself, it's not even 2. It's around 2. Most likely, if you really wanted to tackle this, I think this could be with the new stent platforms, the 2.0, for example, from Medtronic, the Onyx. It's something that could be feasible, but considering the complete data, the patient's age, and the data that I showed you regarding complication, I elected to discuss this with the team, and then we will go for that mildly tortuous LAD and heavily calcified prox LAD. So we'll go back to what we've done today. So what we've done is we've brought a workhorse down to the LAD. Next. And this is what you see when we try to do the OCT pre-images. So it's actually very tight. Despite moving around the guiding, getting more coaxiality, we were unable to advance. Again, this is a testament to the tortuosity of that prox segment of the LAD that we need to tackle. So what we did next is we brought down a Caravel microcatheter and switched out our workhorse. Next. And what we have right now, as you can see, we've brought up the orbital. And again, my choice for orbital in this case was the need to ablate, but also the need to likely modify vessel compliance. And with the tortuosity, there's obviously some operators will say that ROTA could get through this. However, the angulation of the lesion most likely will create a sort of a bias on the outer side of the LED, which will not allow us to fully ablate the calcium and modify the vessel compliance. So with orbital, as you know, it's a 1.25 crown that is asymmetrically mounted, and that could go antegrade as well as retrograde. So this will allow us to eliminate this bias that we might have with the other modalities for atherectomy. I think that obviously if we could always try to push forward to see if we could dilate an IVL, but here in this case, based on the imaging that we have for by angio only, not by intracoronary imaging, we'll go straight ahead with atherectomy. So we're ready to move forward. We'll just move forward. I'll see if I can head into the lesion and start ablating after. Avance avec moi. Ouais. And as you can see, I can cross with the crown. So this is actually good. And we'll start now. So you go always gentle. The clock set on the orbital is actually 25 seconds, and I actually try to do between 15 and 20. As you know from all the orbit data, there's a risk for dissections or no reflow, higher as observed by the trial. The success was still high in the high to mid 90s, 92 to 93%. However, the need for addressing dissections and no reflow was higher in such a trial due to the fact that a lot of people will start with higher RPMs. So I'm electing to go with the 80,000 instead of 120. So this is the second run. And the important thing with orbital is that if you hear, when I move into the lesion, there's this high-pitched noise. Those who do orbital know that this is actually important to modify. And as I go further down, you hear the noise as well. Okay. So again, I always the nursing staff knows when I do. I have two separate a timer for the atherectomy itself, and a timer for the rest in between. I think this is very important and key to try to prevent. Will this prevent 100% that I won't have any slow flow, no reflow? Obviously not. There's nothing 100% in life. However, I think this puts a better chance on our side to ablate adequately. So here you hear different noise. When I go back, you still hear the noise. So I'm moving forward.
Especially here.
I'm really ablating close. Okay. I'll switch over with my fellow, let him do a few runs because the noise is not completely smooth. We'll wait a good 20 to 25 seconds before heading forward. So this has the advantage of, as you saw, doing retrograde as well as antegrade. And I started within the lesion, slightly into the lesion. You hear the noise, go forward, back a bit. There's noise. There's the noise again. Yeah, go back a bit. So again, if you hear the pitch that changes, that means you need to ablate. And we're close to 20.
Yeah.
Got a clock again. So the difference with the sort of, I depends on the operators. I tend to do a quicker way of ablating when I do rotas. I call it the quick and dirty way. Whereas with orbital, I think there is a lot of patience to be had and to really listen to the modification of the pitch. And obviously, the more time you spend within the lesion, the more time you will get favorable vessel compliance modification. Okay, we can do another run.
C'était 178.
Oui, on va donner 3000. So if you hear, there's high pitch there. So sometimes you easily, instead of doing 2 to 3 runs.
We're already through, right?
Yeah, we're through.
But here it's still high pitched.
Yeah. Go back. Back more. Yeah.
There, yeah.
Forward.
Here's where the main work has to be done still.
Okay. Stop. Okay. We're good. So this is where we are actually quite happy.
Mm-hmm.
The noise that you saw at the ostium is still different and also at the level of that first septal. And again, we're waiting really, I mean, it's a question of being very patient with what's going on. Okay. Voilà. Avance un peu.
It has certainly changed.
There's some EKG changes, so
No,
we'll.
it was from the
Oh, it's just in the
from
previous
his
semi.
serious
That's
team,
true.
yeah.
My bad. Okay, we're focused on the case, so back a
There,
bit.
yeah.
Go back. There's still noise there.
Yeah.
Forward a bit, slowly. Okay. Okay. So we wait again, then we'll see how it goes. And obviously, while we do this and due to concerns with slow flow, you always have your medication of choice. Our lab usually prefers instead of adenosine, verapamil. So we have intracoronary verapamil that is ready to go. Okay, I think we do 2 more runs
Yeah,
and then
sure.
we'll see.
There.
Yeah, the pitch is different there.
There.
Yeah, this is not bad. Okay. Yeah.
I think
Yeah.
main thing
Yeah.
is already done.
Yeah.
There.
Okay. Go back. Okay, there. Stop. We'll do a bit more there. I think
Yeah.
this will allow us
On the
to.
distal side.
Well,
Or
distal a bit and then more
there.
proximal,
Sure.
because that noise was
Yeah.
actually higher pitch there. So it is controversial for some, I guess, with that big ramus branch. But if we follow the data from complete, it's not a 2.5. So this is really, I think, doing what is necessary for the patient for us to get the best outcome in the current, more complex clinically and angiographically situation. Okay. Okay.
Right.
I think we're good.
Yeah.
Okay.
Sure.
All right. We'll lock this up. Put it light assist. Let's see. We'll pull this and see. Est-ce que la machine d'OCT est disponible ou elle est déjà utilisée? On va la prendre. So we're actually getting this. As you can know, as with Rhoda, this is a 2-man operation. Versus a 1-man operation. And it's actually good learning tips for those who don't do it enough or often.
Caravelle.
Le Caravelle.
You do a quick image, or do you want to just bring the Caravelle and the BH?
Yeah, yeah, we'll do it. Ça va, monsieur? Ah, ben c'est correct, dormez. On va vous donner un petit quelque chose pour le confort. So the patient is moving about because c'est 50 de fentanyl. We're going to give him some more medication to be comfortable, as none of us know because we've hopefully never been on a cath lab table, but it's likely not as comfortable as a lawn chair.
No, for sure.
So we're going to make the patient comfortable, but there's actually right now, other than his previous STEMI EKG changes, pressure, as you can see, is at 120 about. And attends un peu, recule, enlève la machine, enlève la machine. And there's no instability. And we're just switching out using the same caravel that we use. We're going to get a BH to have support. then we'll get some imaging done, intracoronary imaging. Since everything is fine clinically, and this is habit, right? We're always used to having angios, but the patient is stable clinically and hemodynamically he's stable. So I'm choosing to keep my contrast for the OCT. So as you know, from the Montreal Heart this afternoon, so we're sharing the OCT. So le BH, one of the key questions I had in the initial, you got it, was actually what kind of imaging modality? Of course, as I mentioned, Renovate complex PCI used mostly IVUS. However, my personal preference is OCT, especially when you're dealing with calcium. The calcium score is actually very good. Okay, so I see that we have a question from the audience. I learned a lot watching your orbital kids. Where should it not be used? I think orbital is more versatile. Thank you for the question. Orbital, in a way, is more versatile. However, very, very tight lesions are a bit tougher. Subtotal lesion, I think, are a bit tougher. The orbital, for example, will tackle tortuosity. And most people will know that you don't do rota in circ, for example. Whereas orbital is actually my preferred go-to if I have a left main into circ. The calcium, as long as you have a lumen of at least around 2 to 2.2, you're good to go. I've done very tight lesions as well, tighter than, say, for example, something that would have an issue with a 1.5 crossing. And I've been okay, but really the main difference that you need to bear in mind with orbital versus rota is really the patience that it requires. So if you're keen on going, fast during your PCI, then obviously orbital will not be something that will please operators such as that. However, in our case, this is a tortuous calcified with possibly a nodular calcium versus the tortuosity. And this is why I elected to choose that. More user-friendly than rotablator. I think I wouldn't say one is user-friendly. It's just a question of experience. We're all interventionalists. We like playing with our toys, and it's just a question of getting a few cases under your belt. If you have rota experience, it's really not something complex to move on to. What you have to change when you move from one modality to another is your mindset. The mindset is really how you change it. And Marcel is now certified for he's done most of his cases with me, certified, and really it's a switch.
Yeah,
in terms of the mindset, and be really patient and cognizant of the noise.
Yeah, there's no rush in trying to go from point A to point B and just cross it. It's just to keep inside of the lesion, try and prepare it.
And those who are less comfortable with the issue with burr entrapment will, I think, prefer having the orbital. As you saw, it's a tight lesion that wouldn't even fit, that wouldn't even allow an OCT to cross. And I actually crossed with that 1.25 burr and started within the lesion. So the main thing I see when I think about orbital is really how you can deal with an example, and we all know this, the publications in JAC or JAC imaging are clear on this, that now that we do more imaging, we see the subtype of calcified lesions, such as the nodular calcium. And whether it's balloon, high-end balloons, such as IVL, OPN, you all know that they will expand on the side contralateral to the stenosis. Whereas with rota, you will ablate with wire bias. The wire bias is something that has to be bear in mind. Okay, well, I think we're good there. Yeah. And okay, stop. Regarde celle-là. So as you saw, after orbital, now we've just crossed with the OCT catheter. So this is good. So we'll go live. Was there another question? Give me a second. I'm just gonna, okay, auto calibrate. I hope you're seeing our images, our OCT images. I don't know if you're seeing them. Someone can let me know. Est-ce qu'on voit bien les images d'OCT? The audience, maybe the Mestream team can confirm that we're seeing that we're seeing the OCT. Oh, okay. So I'll do the.
Yes, we are.
So we've done everything.
You want to do a quick test to see if
Yep.
that's okay?
Yeah. Yep. Okay. Okay, we're good. All right. Pousse un petit peu, get une petite affaire dedans. So we'll just make sure we're really coaxial. All right. So we're good to go. Enable. Okay, je peux pas voir. Okay.
It's got a slow flow.
Oh, there's a slow flow from a wire bias distal, as you can see. Okay, on va sortir ça.
Yeah.
So as you can see, you know that there's actually a wire bias lesion at that very mid to distal lesion beyond S2 or S3 even. Tire ça. Tire-le, sors ça, puis on va peut-être retirer la portion souple.
Maybe air got in. I don't know.
Yeah, we could give some nitro as well. So this is really from wire biasing. It was a very tortuous, as you can see from the OCT, it's circumferential. And you see ablation. Clearly.
We have verapamil, right?
So this is why we I think angiographically took the right decision. Verapamil aussi. Verapamil ou nitro? Donne-moi nitro pour commencer. Nitro 1, si ça va bas parce qu'il n'est pas hydraté, on peut donner Néo 100. Okay, can you show us the OCT images? Just gonna push down.
It's better already.
It's already better, but there's that bias that you can see. Regarde celle-là. Okay, so if you look at the there's some ST in lead 2. What we could do is wait, give me a second. We'll pull this slightly back to help with the biasing. Yeah, so the bias, as you can see, the bias is much better. So we leave the floppy part distally. So I think if we need support, push it forward, and then we'll see. Okay. Patient is still stable. Hemodynamic, this is the pressure post nitro. Okay, so if we go, we look at the OCT. Can you start at 20, please? We're getting assistance from Mike from the Abbott team. So thank you, Mike. So you can see it's not fully 2 quadrant. However, now there's deep calcium beyond 2 quadrants. And now it's clearly circumferential. But this is post, again, bear in mind that this is post-orbital. All right, so post-orbital, we're seeing heavy calcium and that is ablated already. There's no real cracks. I don't see any fractures. Go back more. There's some tissue. Oh, that could be, yep, that there. Go back maybe 1 frame. There could be some fractures there at 12 o'clock. Next, go back. But there's clearly some ablation here. C'est pas du verapamil, on va lui en donner aussi. I'm going to give some verapamil as the ST. There's some ST, but in lead 2 and not in so there's actually heavy calcification with really no fractures proximally and distally. Can you go in the prox LAD around 35? Around 35? Because if you remember from the spider view, 35. Okay, go. Let's see if we see the circ. I don't see the circ, right? Go. Can you swivel the blue and yellow lines for me to see Yeah, there's this. Okay, so you see, go back, put it at 4. Yeah, around there. Go around 36, maybe. Us, this is the left main.
All right.
Go in, go in, go in. So we really have to do this osteo lesion. Really, this is as expected. Go more, go in more, more, more. Okay, so there's an artifact. I think what we'll do is we'll size this. Maybe go at 18, and then we'll size there. Go back a bit. Go back a. Okay, size around. No, go closer to 20. Sorry, back around there. We see that it's more fibrous than fibrocalcific. And if we look at the contour, it's a 3.0. So this is intraluminous, not even EEL to EEL. Obviously, the EEL is a bit tougher to see here. So from the left main, can you put a bookmark, Mike, please? See bookmark there. And then second bookmark at 35. So it's maybe 35. Yep. Okay. That's the left main. Okay, there, maybe another bookmark, and measure the distance between both bookmarks for us, please. So a 15 millimeter stent. So if we take an 18, we'll have more leeway here. I think this would be the more appropriate way of proceeding. So let's see.
Yeah, the calcium was quite thick. Do you think it should?
We could do IVL.
Extra?
Yeah, we could do IVL in this case also. Again, IVL I think would be good. Est-ce qu'on peut avoir un ballon Shockwave 3.0? You go back to maybe 30, Mike, if you could, around 30 for us. Mike, if you could go back to 30 for us, please. So go back even further, close to
27, 28.
27, and you can see their circumferential. There, more. There's deep calcium, not just superficial calcium. And there you see it's circumferential and deep.
Yeah, especially here.
Here,
especially
around
here. Yeah.
Yeah, so close beyond what we thought. We heard a lot. So this is clearly calcified. Shockwave 3.012. So we only have a 3.5. So we could go 3.5. We'll go timidly with a 3.5 because we have no 3.0. Unfortunately, I thought we had 3.0, but I guess in the meantime we have 4-path lab running. Probably the 3.0 was taken. So due to the imaging that we managed this again. In a lot of the literature that you see, either from OCT or imaging, a lot of people tend to think that it's actually the pulse that is influenced by intracoronary imaging. Kevin Croce from from Brigham and his group actually looked at the workflow related to the use of OCT, the MLD max approach, and over 2/3 of the case, the modification in terms of the PCI and strategy PCI was in the pre-stenting. So this is actually a great case showing us that by doing the imaging, we actually have to complement one calcium modification therapy with another. So what we're doing right now is getting ready for the IVL.
Shockwave.
And shockwave, yeah. As you know, it's not always something that, so we have a 12 millimeter balloon, and the lesion that you saw is around 16. So we'll go a bit beyond with the 12, and that the imaging allowed us to see that we were good with the ostium as well as the mid portion of the LAD. So the prep is a bit, right now things are stable. The STs are
Yeah,
good.
he got back to normal. Well, normal.
Yeah.
He's
Well,
normal.
his normal.
Exactly.
Maybe in the meantime, what we could do is add another
It was
three.
like
Okay, so we'll add maybe the next five while we're waiting. His heart rate has not dropped. His STs have improved, which is sort of odd because it's actually lead two and not.
it was a good call to realize it was a wire bias because
Yeah.
it had a quite significant loop, and
Yes. Oh, watch out.
that's what it actually
So
brought
it
this slow flow.
helped. So we actually, this is, I think, another PCI in my day with. We did a bunch of PCIs this morning already, and we actually had another case of wire biasing. Attends, ils sont pas prêts encore. Que... Non, on fait. Oui. We can move it to the other room. Attention, c'est attaché, hein. So as you know, we have two cases. Non, donne-moi la seringue pour préparer. La seringue pour préparer. Non. So as you know, the IVL requires, donne-moi de quoi préparer, a special prep, a good prep. La seringue de colorant, s'il te plaît. So it's not as simple. Éloigne-toi un petit peu parce que je veux pas accrocher ton visage. Des fois, je tire fort. So you need three good pulls on your syringe to make sure that if you, I don't know if you can see closely or not, but there were air bubbles still coming back after the second, and now there's more bubbles coming back. And this is already after a prep by our scrub nurses. So I'm just adding more because you really don't want your any air because of acoustic shockwave transmission. And also, there you go.
Yeah,
You see
there
more
you
air.
go. There you
So
go.
this is three preps. So it's really important to take the time to improve conduction medium. There's actually an interesting small monocentric publication on the by a French group regarding standard saline. Vas-y, donne-moi un peu de. Juste donne un peu. Tourne un peu. Tourne encore. OK, stop. On va faire négatif ici. OK. All right. We're going to go.
308 ACT.
Is it 3.5?
308 ACT.
Okay. 308. We're good. So again, we're going to move beyond the calcified angiographic calcified lesion, as you saw. This is a 3.5, so we'll go very gentle.
Let's see how about the profile of this balloon.
Yeah.
In this concentric deep calcium ring.
Oui, c'est bon.
Yeah.
Yeah, so this is where
Let's try improve a bit our support.
we'll improve our support again. Orbital went through. It's tough.
It's tight.
Okay, pull back. Maybe.
Yeah.
Okay, so it's okay. Pull this
going.
out.
Yeah.
It's not going. Pull this out.
We're gonna start with a
Oh,
30NC.
yep. NC30. We'll do a 30 NC. Fortunately, this won't cross. Again, this plays to the calcification and also the tortuosity of the lesion. So, on va prendre un 3, on va prendre un 3-0 NC. So we're going to try a 3-0 and see if this moves forward. If that doesn't work, we'll contamine le pas, tu le tiens. OK, il faut vraiment mettre de quoi dessus. Oui, 12. We're going to go if... Faut que ça soit mouillé. Ça. Non, c'est ça. Il faut que tu trouves la loupe. Il est où le... OK. We'll try this. If that doesn't work, again, it's a issue of support. Peut-être retirer ton guiding un peu pour qu'on ne dissèque pas le tronc. Because obviously, if we start pushing
And
this...
we already have a BH, so...
We have, exactly. We already took a supportive wire. We don't have the Grand Slam in our lab. We have the BH. So this will allow us to maybe push this NC forward, and we'll see. If that doesn't work, then we can always try to get away with a guideliner 5.5, which can easily, without damaging the ostium cross, do an inchworming or an anchor technique. That would be the next, I think, solution for us. We'll see what this 3.0 will allow us to do.
Wow.
Wow, it's the angulation. Est-ce qu'on va approcher un guideliner 5.5? So as you see, he's very coaxial. And we're trying to, so we're not close to, okay.
It's not gonna.
Ok, c'est ok, c'est bon. Retire-le. Que je peux avoir le 2.012 ou 2.015. We're going to take a 2.0 as well as the guideliner 5.5. Ouais.
Once again, the imaging is really helping us to understand what's going on, because it obviously makes sense with that deep ring of calcium, 360 degrees.
With an angulated takeoff of that LED, so it's likely, as we saw, not a nodular lesion.
Exactly.
It's really a tortuosity issue. So this is what we're going to try to do. Je peux avoir le 2.0. Let's leave it close.
Yeah.
Don't bring it forward. We'll wait for the 2.0 first.
Compresse mouillée, s'il te plaît.
On va prendre d'autres compresses mouillées, Joliette. D'autres compresses. Okay. We're going to get this 2.0 down, as this is a 5.5 and a 6 French. We'll try to inchworm it forward, and then quickly deliver the, hopefully quickly deliver.
I think it would take the 3.0, going one step at a time, right?
Yep, we could do the 3.0 first. If not, we can always get a 2.5 and then push it more forward. Okay, wait. Can you push it forward? Oh.
Okay.
Okay.
Okay. Actually.
Yep. Perfect.
Yeah.
Okay. Garde celle-là. Okay, as you saw.
Do you want to maybe try and securize it without dancing a bit more with the guideliner?
No, we're good. I think we're good. Push this. We have to act quickly now because he's going to become ischemic.
3.0. Voilà, la NC 3.0.
3.0. Le ballon 3.0. Va le chercher pendant que je fais ça. Donne-moi le 3.0. C'est moins grave. Tiens, occupe-toi de ça. Je vais m'occuper de ça. Vas-y, occupe-toi de ça. Got it. Si devient bradycarde un peu plus, on peut donner de l'atropine et de la néo. So right now, we're trying to work fast. Rapidement. And the 3.0 is through. Okay, pull back the guideliner.
Okay.
And désengage un peu ton guiding pour que ce soit moins agressif. Okay. Watch the wire distally. We won't have bias. Okay. Okay. Good there. Wow.
On a besoin de Néo.
Néo 2.
Je suis ouvert. Je suis pas ouvert.
Néo 3. Okay, so we're having issues now with the pressure. We're going to open this up. Néo 3. Okay, it's opening up. Okay, out.
Do you want to advance there? No.
Ouais, peut-être.
I'll take everything.
Yeah, pull this out. Maybe we dissected We're gonna see what's happening right now. Monsieur, Monsieur, ça va bien? Okay, just pull this
Maybe
out.
the material.
Pull this out. See what's going on. There's no EKG changes. Oh, pressure.
Pressure. Okay, it was the material.
It was
it was crowded in the 6 French cut
yep.
there. Okay.
Okay, so we're good. We managed to balloon this, so we're good. Pressure was a bit low during the maneuver, I guess, as well.
Okay.
We'll see. Okay, we're good for the wire bias as well.
That's right.
Leave it there.
Do I need to be there?
Well, if you can, it'll be tough.
Yeah.
Yeah. Let me give you a test.
Yep.
See?
Okay.
This
It's
very
in the
good.
branch.
Okay, it's in a branch. We'll see if we can. It's gonna be
Same branch.
Yeah, it's the same branch. Tough. It's gonna. This.
Okay.
There you go.
There
Good
you
job.
go.
Okay.
It's the branch in the end.
Actually,
There.
okay. That's
Okay.
good. All right. Got celle-là? Okay, so now we're gonna try with the
3.5 shockwave.
3.5 shockwave. And you saw there was a waste in the LAD, Prox LAD. This is literally where we had that sort of napkin ring lesion.
In the end, the 3.0 are fully expanded, I think.
At the Prox portion.
Yeah.
But not at the. And again, if you remember from the spider view, the left main is very forgiving. So we were Prox in the LAD.
I'll try without the guideliner. If not, I will inchworm once again.
Yep. No. Okay. Here, give me a second. I'll re-prep it. As you see, there's more.
We're not gonna have pressure. Even now, I'm already without pressure.
Yeah. So see, disadvantage of sometimes working with 6. We debated whether or not we should go 7, but 2 preps done, and a third, no more bubbles. Okay. Let's see what
Let's see. Let's see if it wanna go.
Prends des brassards régulièrement, s'il te plaît. And now it's through. Okay.
Perfect.
Garde celle-là. Okay, so we'll go gentle with this. On va commencer à IVL. We'll go only at 4 instead of 6. This is a 3.5.
Okay, yeah.
Okay, on.
Yeah. I'm gonna
pull it's already fully expanded.
I think we're not in the thickest part of the napkin, but it's some captures of the IVL.
Yep. So right now there's too much material. Maybe push it forward a bit.
Forward?
Slightly. Okay. We'll go gentle. 4, barely even 4. Good expansion.
I think it's a bit more proximal.
Ventricular capture, but patient is still stable. Okay, off.
You want to go more proximal?
Yeah. Let's go more proximal. There. Ok. On a besoin de. Ok. On here.
Yeah.
On n'a pas de pression. Okay. So we're going to pull out and we'll see. We're having issues with the blood pressure. On peut se préparer à peu près à faire du 2.
Ça sort avec.
Oui, c'est correct. Faut pas perdre le guide.
No,
I'm going to pull everything out. It's a 3.5 and a 5.5. So our goal, we've delivered what we could in terms of the circumstances, under the current circumstances, and we'll see. Now blood pressure is good. It's really tough, I think. I don't think a 6.0 guideliner would have been good. It was actually tough, as you saw. Pressure is actually much better now.
Okay.
Well, let's show me.
Maybe we could bring just the 3.5 IVL without the guideliner now.
I think we could, but now it's used. So let's just see what this has given us. Oh, it's nice.
Nice and yeah.
It's a nice. Regarde,
But I
regarde
think
celle-là.
the problem with the pressure was that we were inside the 5.5 guide
Yeah,
liner.
yeah, yep. So let's just do a spider view. I think I'm actually quite happy. You see a dissection, so that means we cracked some calcium. Pull back your.
Yeah.
I'm gonna go in a spider view and then see what we need to do. But we've measured close to 16 by OCT. C'est quoi la vue qu'ils avaient? La vue de. Je sais pas si c'est Audrey qui est encore là. Pas aujourd'hui, mais la vue de l'autre jour. Ouais, ça. Non. Je viens de voir la gauche spider en haut. Ouais, ça c'est quoi?
23 gauche, 42 caudal.
So we're gonna go full spider. The exact same view. Okay, let's see. Okay, let's do this. So we've modified this pretty nicely. Again, the curve is there. Could always try to get, like you said, the IVL in
Yeah.
the prox portion of that. Okay,
Yeah.
we'll stay in this view. We'll get back le guideliner, c'est correct. Pas besoin, redonne-moi le ballon. So we did 3 pulses.
Shockwave.
Shockwave, le ballon shockwave. C'est ça. Correct. So hopefully, now that we've modified, it's really, as you can see, it's the angle. J'ai besoin de la seringue. So hopefully we won't need to tackle this with a guide liner. Hein? Pas tout de suite encore. On est en train de l'utiliser. And I don't know if you saw, there's a lot of air bubbles after using it, so that's one prep. I always do 3. Attention, t'es trop proche de mon coude. Je vais... Non, c'est parce que des fois, je glisse ma main puis je veux pas te frapper dans le visage. So we're prepping it again, 3rd time coming up. Now there's less air bubbles. It's really a question of having efficiency in your therapy, maximizing your possibilities of success here. Bientôt. So more air bubbles. Ah. There you go. No more bubble. I'm rather... Donne-moi un peu. Tourne, tourne, tourne. Encore ça.
Okay.
All right.
Let's go.
We're going to head into this view. On va donner la CT après. The nurses and the support team is keeping us disciplined with the ACT. I tend to do it every 15. This is from the bias from my CTO practice. When you do retro, really need your ACTs to be in tune.
Goes nicely through. We don't have pressure, sadly. So.
Oh, we have good.
Oh,
now
we do. Yeah. Okay, I'm gonna
pull
turn it back.
This is good.
Yeah.
Okay, we're happy.
Yeah.
Again, this is a 3-5. I'll go close to 6 atmosphere.
Yeah. Nice waist.
And we'll start.
Check the waist. Yeah, that's the waist.
I think it popped.
Yeah, it popped.
We're quite happy.
Perfect.
Okay. Done with that.
You want to do just one more?
Yeah, well, one more. Give you a test.
Yeah, right there.
This is good. Okay. Oh, wait, something's wrong. Okay. I may have... I don't know.
You finished.
I finished. Okay.
You didn't finish the run before.
I was too happy. Sometimes you're happy with. Okay.
There you go.
Go press that right. So you're seeing that we've covered everything, and there's no snowplow towards the. Okay. No snowplow towards the ramus branch. I think we're good to go for stenting now.
Do you do an OCT?
So it's sort of
Yeah.
unfortunate. The we started. I think I don't know if the Medstream team can let us know, but I think you guys are moving towards the second room, and they are actually right now using the OCT.
Mm,
So what we'll do is we'll stent, and then we'll do an OCT at the end and show you the outcome. As you can see, STs are good, pressure is good, patient is sleeping,
acetate.
and we're gonna get an ACT, a routine ACT going. Then we'll move on to the stent, and then we'll finish up when my colleague is done with the OCT. We'll get an OCT going. So I hope this was of value. Anybody from the MedStream team can let me know if we're requiring to move to the other room yet or not. Okay. You want to give some nitro or
Hey, why not?
nitro and get back? Is there someone from the MedStream team, or you moved to the other room already?
Okay.
Okay, so
Okay.
I can't hear you at all, but I'm hearing a few minutes again for us. So we'll show you the result before stenting. My colleagues are using the OCT. This is post nitro. Did you push the nitro?
Yes, I did.
Okay.
I think I did. Yeah.
Yeah,
Push on
we'll
300.
push it some
Yeah.
more. Pressure is still good. So you do in cases like this, you pay close attention to the areas of
Wow.
this is
It's
a
a bit.
much